thank you everyone for attending this evening. My name is Dr. Sarah Coll, orthopaedic surgeon based in Cairns in far north Queensland. And tonight it's my great pleasure to invite someone I've known for a very long time, Beth Rolten, who is a very senior personal injuries lawyer who has been based in Cairns for many years and is very capable of explaining all about WorkCover to doctors and allied health providers, because we do feel like we are drowning in the complexity of these claims. And I'd love to hear what you've got to tell us about this, Beth. Thank you.
Thank you, Sarah. Look, I hear time and time again from many doctors, many allied health professionals that they get frustrated dealing with WorkCover clients. They'll often not take on patients, and they're not entirely sure what to do when they are met with resistance from WorkCover about funding, about acceptance of claims. So I've really put together a bit of a list of questions that I commonly get asked from doctors, and I'm just going to go through those one by one and certainly jump in if you have any questions. But the idea is to give you just a bit of an overview of the statutory WorkCover space. So I'm not going to really dive into common law claims, really just looking at the statutory WorkCover space because that's where most of your patients will be receiving some benefits. So like Sarah said, I'm the partner and Cairns office leader at Travis Schultz and Partners here in Cairns, and I'm an accredited specialist with the Queensland Law Society. And my sole area of practice is personal injury law, and I represent the plaintiff. So that's the injured person. So like I said, today we're just going to go through and try and debunk some of those myths and give you some practical tips in dealing with WorkCover. So overview of what we'll go through today is who and who isn't covered by WorkCover. It's not always the case that everyone who's injured at work is going to be automatically covered. What's an injury? How to deal with an aggravation of a pre-existing condition. The difference between adjustment to injury counselling and an accepted psychological injury. Time limits when you actually have to lodge these claims and what happens if you don't lodge them within those time limits. A few tips on completing those work capacity certificates, what to do if you want to add in a new injury to an existing claim. What are the rehabilitation objectives under the Workers' Compensation and Rehabilitation Act? Because those objectives are very, very different to the objectives for someone who's been, for example, injured in a motor vehicle accident. So we'll talk about the difference in objectives, and that might explain why sometimes your funding for rehabilitation's not being approved. What sort of funding, what sort of rehabilitation will be approved and won't be approved? What to do when us pesky lawyers ask you for your records? What are we looking for? And there's certainly Q&A at the end, but please jump in if you've got any questions along the way.
I think the GPs tell me they hate the certificates. They must bounce, I think.
I think, yeah, there's not a trick to filling them out, but there's a way you can fill them out that's going to give your patient the best opportunity to get rehabilitation funded quite quickly and reduce the amount of back and forth where the claims officer is going to have questions. So if we can get it right the first time, then it goes through to the keeper and there's not going to be as much back and forth, which is going to take up less time for the practitioner. So worker under the Act, typically it's an individual, so it can't be a company or a trust. It's somebody who's working under a contract of service, and it's someone who has PAYG withholding. So just your typical employee where the employer pays their tax and then pays them. So that's the definition of who is a worker. So therefore only a worker is entitled to statutory benefits.
And some examples of people who aren't,
These are the ones that aren't covered by WorkCover. Now, this is a really tricky one. So you'll have quite often someone who works under an ABN, and so technically they're self-employed or they're employed under a partnership or a trust or whatever the case, or a sole practitioner. The rules about whether they're a worker or not, it's a little bit more murky. Quite often, an employer will say, well, look, come to work every day, wear our uniform, do the work that we tell you to do. use the tools that we provide to you. But rather than us putting you on the books as an employee and having to pay WorkCover insurance and, PAYG tax, you just send us an invoice and we'll just pay you under an ABN. And in those sorts of cases, under the definition of worker, they can still be regarded as a worker. So it's a bit of a deep dive to look at the true arrangement that's in place. So don't just automatically assume, or don't let your patients automatically assume, no, I'm not an employee. I work under an ABN, therefore I don't get WorkCover. We've had plenty of cases where we've challenged that decision because really they are an employee. They've just come to an arrangement about how pay is done. So but then all the other obvious ones, so directors of companies, trustees of a trust, partners in a partnership group, none of those are covered. So if you're in that boat, then you need to go and take out your own insurance to cover you if you're injured in the workplace. Professional sports persons while competing or training, so a jockey or someone like that, they're not covered. Fishing crew.
Wait, so I thought they were trying to change that a couple of years ago.
They may well have, but they haven't.
Football. Yeah. And I have looked after a jockey who was employed by Racing Australia.
So it comes down to, were they competing at the time? So sometimes they may be employed. Yeah. So for example, we've got someone at the moment who he's a commercial fisherman. So commercial fishermen are paid a percentage of the catch, and so they're not covered because of the pay arrangement. But when he was back in Cairns, he was not being paid as a percentage of the catch. He was paid just an hourly rate to do work when the boats were in the dock.
Wow.
So when he was injured in those circumstances, he was covered. So there was a little bit of back and forth. So driving instructors, so they're not covered. So if you're venturing out and going to become a driving instructor, be aware that you're not going to be covered if your learner driver crashes into someone.
Is there a historical reason for that? I mean,
I have no idea.
Sort of
I actually have
excluded?
no idea.
It seems harsh,
They're actively excluded.
Okay.
Then you've got your people who are participating in, I don't know, they used to call it Work for the Dole. I don't know what the correct name is for it now, but those unemployment programs where they go along and work, they're not included. And anyone who's employed by government, by the Commonwealth government, they're covered by Comcare, so they don't fall under WorkCover. So what's an injury? Sometimes, and more often than not, someone will fall over at work, they break their leg. It's so clearly an injury, we don't have to go any further than that. But where you might have an aggravation of a pre-existing injury, that's where it can become a little bit difficult. And you might have a doctor going, yeah, but you've always had a bad back. You've got all these pre-existing back injuries and you've gone to work and you've done something at work and it's made your back worse, but you always had a bad back. So, you can't say that that's a new injury. It's not a new injury. It's an aggravation of a pre-existing condition, and that is an injury. So that falls within the definition. So the worsening of that condition because of what happened at work means that that particular worsening will be covered under the statutory claim. So they can have treatment for the worsening, they can have time off work for that worsening. So simply because they have a pre-existing condition, and everyone would know, I think by the time you're about 25, you're starting to get degeneration in your spine. And if everyone had MRIs, we'd probably see a number of conditions that are completely asymptomatic. So we'll often...
Isn't there like a 50% rule? It's got to be a 50% aggravation. Is that an orthopedic myth?
That's an orthopedic myth.
Myth, yeah.
I think I know where you're going, Pat. I think more likely than not is greater than 50%, but that's a totally different...
That's a myth, yeah.
It's a myth, no.
Can I just pull you back? David's concerned about the driving instructors. He wants to know if they're covered under CTP.
Well, yes, if the other driver's at fault.
Oh, of course. Right.
So
they have no cover at all.
They're running.
You're really concerned about these driving instructors today.
My daughter's about to get a driver's license. Yeah. They're hanging on to that. to the vehicle. These poor guys are in the car with a learner driver. That's a terrible experience.
Yeah, no, taking your life in your own hands there.
Yeah, okay.
So other
Sorry.
diseases, exposure to chemicals, dust, those sorts of mesothelioma, they're all considered injuries. Industrial deafness is considered to
And
be
you
an
do
injury.
dust diseases as well, Beth? You cover them in your
Yeah,
practice?
yes, yeah,
Yes.
we do all of the
Mm,
injuries.
mm,
Industrial deafness is a fairly common one, so people can get some compensation for loss of hearing if they're working in a particularly noisy environment. Obviously, psychological injuries are all covered, and death is defined as an injury as well. So
mm,
it's got a pretty broad range of injuries. The thing that is most important, though, is that you have to show that employment is a significant contributing factor to the injury.
mm,
So, say, for example, you have a person at work and they're going about their business at work and they suffer a massive heart attack and pass away.
mm,
Unless what they were doing at work significantly contributed to that heart attack, then even though it happened at work and even though it falls within the definition of injury, it's not going to be accepted
work related.
unless you can prove that employment significantly contributed to the heart attack. So those are really, really tricky ones.
Mm,
And thankfully they're few and far between, but that's what an injury is. So really, probably the thing that I just really want to highlight is that aggravation. There's often a school of thought that says, oh, well, you already had a bung knee or you had a bad back, or so we can't claim this as work related because you already had an injury. If it's been made worse, permanently made worse, so not a temporary exacerbation. So permanently made worse means it's an aggravation. Temporarily made worse, then it's just an exacerbation. So if there's been a permanent worsening, we can claim for that permanent worsening.
mhm.
So moving on. So, and this is, again, I dwell on about aggravation of pre-existing conditions. So as long as you can show that there is a permanent worsening and you've got some medical evidence, in an ideal world, you'd have a scan before and a scan after and, it shows up, but that rarely
Sure.
happens. Often people will come to me and they go, yes, I had a claim back in 2008 and, it was for a back injury, but I went back to work and I've been working ever since and I've been having, a bit of physio and whatever to keep me going. And then I've lifted this, wheelbarrow full of concrete and I've put my back out again. And so all of
Mm,
a sudden they're off work. Even though they've had that pre-existing back condition, even though it's well documented and that no one's hiding from it, up until the point of the new injury, they were able to maintain themselves in employment, and now there's been a worsening, so now they've had to take some time off work. So all of that can be claimed.
David's got his hand up.
Oh, have you? Oh, David, yeah.
Digitally, I've got
a digital hand up. Go for it.
With the aggravation of injury, so I've had patients historically that have been very hesitant to get a mental health care referral or to even engage with a healthcare professional for their mental health because of concerns about that being utilized against them in future secondary psych or psychological injury claims.
Yeah.
Is there any difference in the level of support or compensation they get if it was an aggravation of a pre-existing condition compared to totally first ever time experiencing mental health concerns or what?
Yep. Yep. So I'm going to get onto psychological injuries and
Oh,
aggravations
yeah.
and so forth, but it really comes down to your expert evidence in that case. So what we'll often do is we'll send the client off to an independent psychiatrist, and we'll say, look, they struggled with depression in their teenage years. Their mother passed away when they were 30, and they had a period of depression then, and they had some counselling. They were prescribed antidepressants at that point in time. They continued taking those for 4 or 5 years. Some other bad things may have happened. We give that entire history to the psychiatrist, and we ask them to say, well, is this an aggravation of a pre-existing, or is this a standalone discrete psychological injury? And even though they may have had some vulnerabilities because of what had happened previously, that this is completely related to work, and it's not some kind of aggravation of one of their previous conditions. So it's a case by case scenario where we really rely on expert evidence to tell us what's going on.
Just to interrupt you, David, I'm sure you've got something to say to that. I guess what it sounds like you're asking is, we try and very hard to sort of make this kind of ad hoc assessment of what we think is pre-existing, and what, and we try and help the patient work it out. Is it worth going for this claim? But what Beth's really saying is, we've got no chance of knowing that, because it's going to take an expert to. That's pretty daunting, because we do try and anticipate things, Beth. We try and say, oh gosh, and I
it's
think, probably not going to fly. And
to just get the claim lodged, because really the patient is the best person to ask in terms of, well, what was your symptomology before this happened?
Mm-hmm.
And what is it now? Or if it's clearly they're reporting that it's made significantly worse, and then like WorkCover will do their due diligence. They'll go and get all their GP records and have a look. And it might be the case that, they've had occasional back issues in the past, but it might be 3 or 4 years since they've had treatment. So, it really shows that they weren't needing treatment. They were coping at work. They were doing their job day in, day out without taking any days off work. And then this event happened. So even though they've got that history of back issues or whatever case may be, you can clearly show that there's something significant happened on the back of them already having some degree of vulnerability.
Yeah. And mental health is an interesting one, because the level of adversity somebody's had, it's that U curve. So if they've had a little bit, then they may actually have better resilience than somebody that's had nothing. So if they've become fully functional following a previous diagnosis or treatment for depression or adjustment disorder at some point in time, there's almost some argument to say, well, their resilience may have been higher than somebody that had nothing.
Exactly. Yeah, exactly. So that's sort of how pre-existing. So don't be put off, I guess. Don't be put off by lodging claims for a patient who already has a pre-existing condition, particularly if you think that there has been a worsening of their symptoms because of what's happened at work. So this is, getting into this acceptance of a psychological injury into WorkCover. What we find is such a common trajectory for people is they'll have an accident at work, a physical injury, and they, are quite motivated and keen, and they start off with their physio, and there's hope that things are going to get better, because every other time they've hurt themselves, they've got better. And they have a bit of time off work, and they're having their physio, and they're doing their exercises, and they're engaging with all their treatment providers, and things are not healing as well as they would have hoped. And, their spouse is, getting fed up with them, and they're not able to play with their kids like they used to be able to, and they can't, go fishing
sell
anymore.
the jet ski and
yeah. And so just over time, they start to decompensate, and they start to show signs of, psychological distress, and they may speak to WorkCover claims officer about that. They may speak to their GP about that. And what WorkCover are doing, because there's been a real increase in these secondary psychological injuries. So over the last decade, they've almost doubled in numbers. So WorkCover's acutely aware of that. So what they're doing at a fairly early stage is offering adjustment to injury counselling. And so that adjustment to injury counselling is 3 or 4 sessions with a counsellor to help that person adjust to their new normal and accept their new normal and move on without hopefully developing a full psychological diagnosis. That patient will go and speak to their GP potentially, and they might go, yeah, WorkCover's organised some counselling for me. So the GP's like, sweet, I don't need to do anything more. WorkCover's taking care of their psychological symptoms. I'll just keep focusing on their physical injuries and what I need to do there. I don't need to refer them off to anyone. WorkCover's taking care of that. And the patient thinks that that's right, my psychological injury is being addressed and being taken care of. I don't need to do anything more. And where there is confusion is there isn't an accepted psychological injury. There, by having adjustment to injury counselling, it is simply a free counselling service to help them out. It is not acceptance of a psychological condition. So the client goes, oh, yeah, my claim includes a psychological condition. The doctor's like, okay, great, I don't need to do anything. And then we get to the end, they're, back, knee, shoulders healed up or, as good as can be, but they're still really depressed. And WorkCover cuts them off and says, well, that's the end of your claim. Your shoulder's stable now. But meanwhile, they've spiraled into a depressive state, and that's hampering their ability to work, and they need some more counselling and help to deal with that. But WorkCover's like, oh, you don't have an accepted WorkCover claim. You don't have an accepted, psychological injury claim. You've only got an accepted physical claim because your GP never put a psychological injury onto your medical certificate. And so everyone's thinking someone else is dealing with it. The absolute only way to get a psychological injury accepted by WorkCover is to ask them to accept it. And the best way to do that is to put it on the medical certificate. So if in doubt, just put it on.
What do we need to put? So do they need a full-on DSM-3 criteria diagnosis? Oh, sorry, DSM-3, that's showing my age. Do they need a full criteria, or do we need to say,
you
psychological
go to your
injury?
WorkCover, that little tiny square that you have on your WorkCover capacity certificate to put all the injuries in?
Yes.
You squeeze in there psychological injury. You don't have to put a diagnosis. You need to put a psychological injury. You can put, then there's a recommendation for treatment, have some counselling, and then WorkCover have to make a decision on it.
Okay.
So, and then they have to either approve it or not approve it. And then we can deal with it if it's rejected. But, if they've had adjustment to injury counselling, they'll often speak to that counsellor and say, is there something more there? And that's how they'll make a determination on that. So biggest take home there is if you've got a patient who you believe has a psychological injury, make sure it is put onto the WorkCover capacity certificate. And you can add it afterwards. David.
Is that GPs and orthopods? Does it need to be psychiatrist?
It can be anyone who's able to complete a medical certificate.
That's interesting, isn't it?
Usually it's a GP. Yeah.
But I do get asked to do it, and obviously I don't. David, as you know, I don't feel like I've got any expertise, but you're right. If it's just a matter of initiating if this allows the patient to initiate the conversation, I'm advocating on behalf of the patient, then I think I feel much more confident doing that.
Yeah. And I think probably if it's outside of your specialty, then that's where it's really good for specialists to have a good relationship with the referring doctor, to write back to them and say, hey, we had a chat today. I think there's a psychological injury there that needs to be formally accepted by WorkCover. Next time they see you for their work capacity certificate, perhaps have a chat to them about whether that should be included.
David, did you have something else?
So it's kind of getting the conversation started if the GP isn't confident, but it obviously seems like there's some level of distress without there needing to be some formal diagnosis. It's within their scope to say there's distress going on.
Yeah, absolutely. And leave it to someone in the right specialty to make the diagnosis. Yes. But just to get something accepted, because, you'll see 10 different psychologist or psychiatrist and you get 10 different diagnoses. So the
Yeah, fair
diagnosis
enough. Yes,
isn't necessarily the be all
isn't
and
the
end all,
issue.
but
Right.
just make sure it's accepted that there is a psychological
An
condition there
injury.
that needs to
Yeah.
be dealt with.
That's helpful. Thank you.
So this is another one, and this one I get
This
really,
is
really
your
concerned
particular,
about. It
yeah, you
is, I
don't
get
like this.
so worried because I don't think any GPs, unless I've done a chat in their
Talk. Yeah, yeah.
GP clinic, are aware of how significant this 6-month time limitation is to lodge a work cover claim. So this is just to get your entitlement. So this is your statutory claim. This is not a common law claim. So you've got 6 months from when your entitlement to apply for, compensation, workers' compensation,
Yes.
from when your entitlement begins. Now, when does your entitlement begin?
Mm-hmm.
It begins on the date that you're registered, that you're assessed by a registered practitioner, medical practitioner, say a GP, a
And so if they
dentist,
write,
or
presents with left knee pain and don't sort of talk about an injury or anything, is that still reasonable? Do they
no.
still accept that?
So it has to be the consultation where the injury
Mm-hmm.
and work are linked together.
Interesting. Okay.
Okay, so if you've got look, it's so straightforward. If you fall over, you break your leg, you go to the doctor that day, your date of
Yes.
entitlement starts, everyone's happy days. There's no confusion. They're not the claims that I'm worried about. The claims I'm worried about are where patient turns up, talks to their GP and says, my right shoulder is really giving me some grief. And the GP says, oh, well, look, go and have some physio, come back and see me. If that doesn't work, they come back and see them and they're like, all right, well, maybe go and have some injections, refer them off, see if that works. Okay, no, it doesn't work. All right, go and see Sarah, see what she has to say, might get an MRI at some point. That's all fine until the point where the patient says, by the way, I work at the meatworks and I spend my day reaching above shoulder height to bring down these carcasses of meat. And I do this repetitively all day, every day, and I don't get a break. And that's really what really hurts my shoulder. Once you've linked, okay, the shoulder that's starting to give him grief and the work duties, that's the date. Okay, so it's got to be the connection has been drawn that it's work. Same with, and probably more so. So that date, you've got 6 months to get that work cover claim lodged.
Well, come on. Sorry, I'm just going to drag you out a little bit. One of the ones I've had was language difficulties. So it was clear after some minimal questioning that the patient had no understanding that compensation for an injury would ever, it just didn't, their cultural background, there was no such thing as compensation. It never occurred to them. And so now we were sort of 7 months after the injury, and maybe she dropped into a GP once and mentioned the shoulder, and then, maybe she had a steroid injection, and then she sort of came to me, maybe, well, carpal tunnel. Carpal tunnel is the best one because they sort of, I've got pins and needles, tingling and numbness. And then at what point do you actually refer for a surgical intervention? Well, once it's symptomatic enough. Well, how do you know if it's symptomatic? Well, you could do nerve conduction studies, but that's a 5-month wait potentially, right? So what happened with this patient was, there was a delay to presentation to the GP, then a delay to diagnosis through no fault of anyone. It's
regional
systemic.
practice. Yeah.
And so now we've got a patient who's too far down the track, and I'm trying to explain to a patient with limited English that they're not, that potentially they're not entitled for compensation because of the systemic delays. Is there any sort of recourse to kind of?
Well, there is two things. If the person's saying, I spend my days doing something very repetitive, which is likely going to be the cause, and there's definitely some issue going on. The diagnosis doesn't have to be spot on, but if there's some issue going on and there's a link to work, then it is absolutely incumbent on the GP to maybe just warn them, go, look, you've got 6 months to lodge this claim from today. So if you want to get workers' compensation benefits, you've got 6 months from today to lodge it. We can lodge it now. We don't have a fixed diagnosis. You can put, wrist pain likely linked to repetitive tasks at work, and then you've just lodged it. We can deal with the diagnosis and all the different scans and
Yes,
things that have
yes,
to happen after
exactly.
that. So you're
Yes,
not going to miss
yes.
out. And the better way of doing it is have it lodged, have it accepted, and then WorkCover's funding those scans.
Yeah,
So
agreed.
you don't
Okay.
have to go through and get everything done before you lodge the claim. Once there's that link, there's an injury, there's something going on there. We're not entirely sure what it is, and it definitely seems to be related to work. Lodge the claim.
Wow.
Um,
Sorry to
but
interrupt.
the other one, you'll have someone come in and talk to their GP and go, I'm working. Trying to not suggest one of the common workplaces. I'm working at an office,
XYZ.
and my boss is really giving me a hard time. They're picking on me. They're just constantly criticizing me in meetings. It's really weighing me down. And they're having a bit of a frank discussion with their GP about what's going on in the workplace. And, they don't want to lodge a work cover claim at that point in time. They're just, talking to their GP about, coping strategies and what they can do and what
Mm,
options are available to them. And the GP's like, well, maybe go and do a course, have a, try these options. They go away, they come back 6 months later and they're like, oh, look, it's so much worse. I can't sleep now.
mm,
I'm taking
mm.
days off left, right, and center. I feel physically sick when I'm in the office with this person. If they haven't lodged that claim within 6 months of when they first went to the doctor about the bullying and the psychological
Mm.
symptoms that were arising from that, they're out, and they're the ones that I'm commonly seeing being lodged late because just the nature of the injury, that sometimes it just does take that long, and there might be flare-ups of things that are happening in the workplace. So work covers, as soon as you're lodging a claim that's where an injury's happened over a period of time, the first thing work cover are going to do is write to the GP and say, when did they first come to you? When did they
Mm.
first come to you about
Hmm.
this?
Mm.
And if it's more than 6 months ago, claim's rejected.
Mm.
So they miss out
Wow.
on
Mm.
counselling, they miss out on lost wages, they miss out on their lump sum benefit at
Mm.
the end, they miss out
Mm.
on, so it's really it's just so important that it is lodged within that 6 month
Mm.
from that
Mhm.
date of entitlement. And it defies logic because obviously the person doesn't want to lodge a claim straight away. It's a bit of a, we'll
Yes,
do it if
it's
everything
very
else fails.
confronting.
I just want to
Mm.
see if I can work
Mm.
it out. Things just might get better. I want to give it the benefit of the doubt.
Mm.
But that's the way it is. There is provision to accept the claims that are lodged outside of 6 months if there's some kind of extenuating circumstances. I could count on one hand, I could count on one finger the number of times I've actually seen work cover accept a claim that's been lodged outside of 6 months.
Oh,
They
wow.
they just are like, no, it's rejected. It's out of
Ruthless.
time.
Wow.
Yeah, it's pretty ruthless. So the 20
Mm.
business days from back. So from the day of entitlement, they've got, if they lodge their claim within 20 days of that, they'll get back paid to the date of entitlement. If they lodge it after the 20 days, they'll just get back paid to the date that it's lodged. Um, and then, like I did say, there's potential exceptions, but they are rare.
Okay. Okay.
So tips on completing your medical certificates. Um, the doctors can do it. It can also be done by a dentist or a nurse practitioner. So
Hmm. Hmm.
more often than not, it's your GPs who are doing those medical
Mm.
work capacity certificates in the first instance. You really want to make sure, and again, the space to complete and write the circumstances of the incident is pretty small. So there is a real
Yes, it's
temptation
pretty
there to,
challenging.
exercise a bit of
Summarize.
brevity and just,
Mm.
fell at work. Well, if you write fell over at work when in fact they slipped at work,
Yeah. Go on.
then that can be a little bit tricky because if we do get into the
What?
common law claim and we're saying they slipped on, a leaking freezer that had been leaking water out onto the floor and
Yeah.
the place hadn't done anything about it, well, that's a slip. But if the medical certificate says they tripped or they fell, then they're like, well, what did they do? Did they really slip? And so then it just gets difficult.
Oh
So
my goodness.
try to use the language that they use when you're describing how the incident happened, and make sure your medical records of that consultation really do reflect what the patient tells you happened. You're going to also need to look at what the injury is, what the date it happened. WorkCover is quite funny, and they'll say, because it's hard to say that something happens over a period of time, because again, you've got this tiny little spot. So you tend to just go, well, the injury happened the day they walked out of work, because they've lost it after 12 months of bullying in the workplace.
Yes.
That's not really, I mean, that's the date that they go to the doctor, but that's not necessarily the actual date of the injury. So we as lawyers get really particular about, well, what is the date of injury as opposed to what is the date of entitlement? They're not always the same. So the date of entitlement is the day they go and see the doctor. Date of injury could be long before that. And for our purposes, particularly for a common law claim, it goes on the date of injury. So, but you don't need to worry about that. You just answer the questions as they are. Oh, sorry, I've jumped ahead. You've got provision in there to say whether they're able to go back to work. If they are able to go back to work, but you really want them to have some restrictions, make sure you detail those. If work covers...
but sometimes I send them back to work and they say, yes, I know you wrote that on the form, but my boss told me to lift that 20-kilo object anyway.
All the time. All the time.
So what do I do for the patient then?
You have to be their greatest advocate, because
they have to write on the form a bit harder.
Yeah, bold.
Press harder. Yeah, bold.
And I think that's where it can be really hard, because you're looking at this lovely return to work program that's been beautifully prepared, and they're only going to do, lifting up to 1 kilometre.
We've discussed it and we thought about it.
Yeah, and everyone's signed off on it.
And we've all agreed.
And then the reality is they go into the workplace and...
Yeah, it's totally different.
It's totally different. Or they go into the workplace and they get sat in the corner and they're given no duties to do, and everyone mocks them, and it's a real disaster. So we are... I'm completely off script here, but anyway, we are really big advocates for getting people back to work. I think sometimes this misconception that if a patient goes and sees a lawyer, they're going to discourage them from going back to work. They're going to keep them injured, and they're going to, it's better for their claim if they're off work. That is so not the case. We are always encouraging our patients to go back to work, and we want them to do it under the direction of their medical team, and we want to do it in a safe environment, because we want to see what they can and can't do as well. Because otherwise, if we've got no idea, how do we give advice to someone who's never returned to work, but we think they could return to work, and we're just having a guess? And it's not the courts, if it ever made its way through to court, the courts don't look very favorably on someone who just makes no attempt to return to work. Yeah.
Okay.
So it's called mitigating your loss. And so there is an expectation that someone who's bringing a claim is going to do everything that's reasonable to mitigate their loss and return to work in some capacity, provided it's reasonable. Okay. So
just to summarize that, when a patient says, oh, I don't think I should go back to work, or that, you sense that, that there's the motivation to not return to work may have been misadvised. I don't even know if that's a word. Or, their friend said, oh, don't go back to work, mate. That's a terrible idea. So I can confidently say to them, you are looked upon more favourably if you have demonstrated that you have attempted a return to work.
Provided the return to work safe. So I'm not saying, for someone who's got a shoulder injury, they should go back to...
psychologically safe? I mean, I sometimes feel that they don't want to go back to work because they are genuinely frightened.
And then that's probably more into a psychiatrist to say, okay, return to work, absolutely.
I need a psychiatrist to help me.
They can't go back to that workplace because that's where the bully is, that's where the trauma happened, that's where, so So yes, that person has capacity to return to some form of work. It can't be in the same workplace around that same person. And then you just have to make a return to work program that accommodates those needs. So
Yeah, because they'll say, or they're a little evasive about it. They're very self-conscious of the fact that they don't actually want to go back to work because XYZ is there, or this circumstance is there, or this person is going to be there. So they get a little bit evasive. And the problem with that we have with that is that oh, I've just got a phone call. Sorry about that. Problem we have with that is that then they're trying to what am I trying to say? It breaks down the communication with the healthcare provider because they're holding back on a piece of information, and you sense that they're holding back, and then you can't quite. Then you don't know if they're telling you about their pain. Do you know what I mean? Or if they're really they're using their pain as a way to express their concern about returning to work. So it becomes hard to manage the case because are they actually sore? Are they actually not moving? Or are they just holding on to this fear of going back to their workplace? So what you're sort of saying to me is that I can openly approach that. So I can say, so I can say, I sense that you've got some concerns about returning to work. Would it help you if we had some adjustment to injury counselling, or would it help you if we incorporated this into the conversation with the caseworker? I mean, what do you think? Just make it safe.
If you've got good relationships with the referring doctors, to go back to them about if you've got concerns that this is now, I think, more of a psychological barrier for them to returning to work as opposed to a physical barrier. I think physically they may be ready to return to some form of work, but I think psychologically there's some barriers there. Refer back to the GP and then leave it for them to refer on to get the appropriate counselling. So it might just be the case that they just need some treatment to help them overcome those barriers and whatnot. So, but definitely, I don't want any doctors or specialists or allied health out there thinking that we as the legal team don't want them returning to work.
Absolutely. We hear that all the time, Beth.
We want them to go back to work. We really, really do, because it's better for them. Like it's just better for everyone.
Mentally, they're so much better off if they're back at work.
And in a perfect world, it's done in a really considered way that is appropriate, and all the necessary people are involved. I guess, sorry, I've got like an influx of bugs in my office at the moment. But what we tend to find is work covers like, when are you going to be right to go? When is this patient going to be right to? And like they just want you to go, they should be right to return to work in 4 weeks.
Yes,
if you say that, if you say they'll be right to return to work in 4 weeks, their claim is cut off, and they are like, well, what's wrong with you? This is you're malingering or whatever the case, because you haven't returned to work and your doctor said you would be. So I would encourage you, if you're having conversations with WorkCover, particularly about when is this patient going to be ready to return to work, add a caveat that says, they should be ready to return to work in 4 weeks if they respond well to treatment. Because there is no rule that says 4 weeks of treatment and you're fine, or, like everyone's different. And so we just have to
put in
that caveat there. So then you've got the ability at 4 weeks when WorkCover's going, well, why aren't they back at work? Why are they still complaining? Oh, look, the treatment didn't respond as well as we would hope we'd like to. And then you can push on for more rehabilitation.
More treatment.
More treatment to get them over the line. But any kind of cut and dry, they will be ready in 4 weeks. And anything more than that is there's something else going on. It's going to just make it very difficult to keep the claim open for further rehabilitation if they don't respond as your typical patient.
As per your timeline.
Yeah. Adding a new injury. So really common that a couple of things happen. So you'll have, and Sarah, you could probably speak to this, You've got Mary, and she's got a left shoulder injury, and she has some treatment on that or surgery, and she develops frozen shoulder in her left shoulder, and she's not using it at all for a good period of time. And now she's overusing her right arm, and now she develops frozen shoulder in the right shoulder. And you're trying to say, well, her right shoulder was fine until she had to use it exclusively for a period because of the frozen left shoulder. So now we want the right shoulder included in the left shoulder claim, even though there was never an issue with the right shoulder. So how do you deal with that, Sarah?
So frozen shoulder is probably a tricky one to example, and calcific tendonitis of the shoulder is also a tricky one, but an easier one might be carpal tunnel. If they present with right-sided carpal tunnel and 3 months or 2 months after their delayed a treatment, delayed a presentation, delayed a diagnosis, delayed a surgery, they start developing symptoms in the other side, there is a risk that it's considered constitutional. You were always going to get carpal tunnel because you got it in the right side and now the left side. So then you're right. It is extremely challenging for me to then add in the second side. And so that tip on your screen there that says, don't start a new claim, just put it on the first certificate, that is extremely helpful, because I think what I'm learning today is we're much better off putting it on the certificate and starting the conversation with the insurer, rather than thinking, I know, the insurer won't look into this and the insurer won't manage this. That sort of defeatist kind of approach. Yes, I keep trying to.
You're the expert. They are claims officers, often with limited medical training. You're the expert. Back yourself. If you think that that's an injury that has solely come about because of that first injury, put it on the medical certificate. They then have to make a decision. They will then go and get some expert opinion. But we can challenge that. If you're really convinced that that is an injury that's come about and wouldn't have come about had the original injury not happened, then it needs to be included. Say, for example, you've got old mate who suffers a knee injury at work, and he has some surgery on that knee, and the knee is now really unstable and it gives way constantly. And he's wandering around his garden on the weekend and he falls over and he breaks his arm.
Right.
Well, that's a secondary injury, and that broken arm needs to be included on that original injury.
On the original claim.
Yeah. Because, well, what's WorkCover going to say? I broke my arm at home. Well, that's not significant work. Work's not a significant factor to that. So that's never going to be accepted. But the reality is, the knee has been giving way. The knee keeps giving way. It's got to be, the fall is linked to that. And if, they've had multiple falls that are documented after the surgery, and there's good medical evidence to say that it's really unstable, then, it's more likely than not related to the instability of the knee. And so then the broken arm or whatever other injury he suffers it should be linked to that first claim. So what we will commonly see is WorkCover will go, well, it's a new injury, it's a new claim.
Yes.
And then you've got this.
I take the caseworker's advice.
Oh, yeah, because.
But go on.
The thing is, and look, I'm probably thinking of it more as a long-term thing for that patient, because if they have a common law claim and there was negligence attached to that original injury, and then all these other secondary injuries flow from that, then they are all covered in that common law claim. But if those secondary injuries are not attached to that, then there's no common law for that, and we can't claim that in a common law claim. So they all need to be grouped together. So put up some resistance if you think that this is all completely related to
Great. That's very reassuring.
Yeah.
Yeah.
And I think, Sarah, not to name patients or anything, but you may recall you had a patient who had quite a bad knee injury, had surgery,
Mm,
then following surgery, got out of the car, stood on the ground, knee gave way again.
mm.
Now WorkCover opened a second claim for that.
Yes.
And we had to go to great lengths to say, no, he wasn't doing anything. He stepped on the ground. He didn't twist,
Yeah.
he didn't turn, he didn't do
Uh,
anything. He literally put weight on the
mm,
knee that he'd already had surgery on. This is
mm-hmm,
100% related to, and we worked together to make
mm,
sure
mm,
that second, because he then had to have surgery again, that
mm,
that second lot of surgery was linked to the original claim, because
mm,
the standing on the ground doesn't cause the injury that had happened. So
mm, mm, mm.
there's a lot of reasons
Interesting.
why we want to make sure that they are
Mm,
appropriately linked to the right claim.
mm.
Um, what else? I think that's probably all. Psychological injuries are the key one. Just always make sure
Yes.
they're included in, but I
Documented.
think we've done that.
Fantastic. Mm.
So this is why you
Yes.
might find that what you're requesting is being rejected. So the main objective under the Workers' Compensation and Rehabilitation Act is to facilitate a safe, efficient, and early return to work.
Mm-hmm.
They are not concerned with making the person better or bringing them back to their pre-injury function. Okay. So
Yeah.
that's
Why not?
because it's get them back to work. We have to do as much
Okay.
as we can to get them back to work, which is very
Yeah.
different to get them better or get them to their pre-injury
Yes.
function. You see the difference? Like you can be back at
Sure
work, but not at
do.
your
That's a
pre-injury
huge
function.
difference.
Huge
Yeah.
difference. So they're the objectives under the work cover legislation. The objectives under for a CTP claim, so a person who's been
Mm.
injured in a motor vehicle accident, is to get them back to their pre-injury function. So it's vastly different. So you'll probably find that your patients who've been in a motor vehicle accident, that the rehabilitation funding is more extensive than what they'd get under
Longer,
WorkCover.
much longer. Yeah, I can
Much
actually get them
longer.
pretty good
Yep,
function. Yeah,
yep,
yeah.
yep.
David would be able to speak to that. But
So that's why you're going to be getting calls from your WorkCover claims officers going, when are they going back to work? When are they going back to work?
yeah,
When
yeah.
can they start and so that's why, because soon as they're back at work, their job is done, they don't have to fund rehab anymore.
So what if they're just doing, part-time, a couple of hours? I tend to find caseworkers will cover allied health support if the patient's doing, host duties or a couple of hours a week, that sort of thing.
Provided the treatment is
Yeah.
enabling them to work more.
Yes. Okay. So we have an incremental increase in, say, their
So,
hours or function. If I can
you're
demonstrate
applying,
that.
if you're applying for further physio or further treatment, and you can show that with this further treatment, they're going to have improved functionality at work,
Absolutely.
WorkCover will
At
keep
work.
funding it. That's going to be
Sure.
fine.
It's about their work function.
If you're saying, sorry, I keep hitting the wrong button. If you're saying that the treatment that's being proposed is to help manage their pain levels and give them better quality of life, really good chance it's going to be rejected.
David, did you want to contribute in this space? This is your
sorry, I've been
specialty.
dropping in and out. I'm not
That's
sure
all right.
why.
No, you're doing great. You're doing great.
So really, we've got to be creative so say they could lift 30 kilos before the workplace injury, and they only need to lift 20 for their job.
Mm-hmm.
Realistically,
yes.
Like it's almost unethical that they're not compensated to get back to the level of function they were pre-injury just to get back to work. So we just need to be creative in how we word what the barriers are to their recovery.
Yeah. And really try your best when you're requesting funding to speak to the functional gains that are likely to be achieved by that treatment.
Yeah, that's really important.
Rather than saying this is going to be really good for them for managing their pain levels.
Yeah.
Okay.
Okay. So if you
The
can
emphasis has to be on their return to work.
yeah, and how that treatment's going to facilitate a better return to work for them and improve their
Yeah.
functional gains at work.
And safe and sustainably means that arguably we could set a certain limit that is actually higher than their work demands, because technically, if you can only just do what you're required to do throughout the day, then your chance of injury is quite high, as opposed to having a capacity above that. Does that make sense?
Yeah,
A
we like that
demonstrated
wriggle room,
capacity
don't
above
we?
that.
Yeah.
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 And I think often WorkCover will engage OTs to help go into the workplace, look at what the person's duties are, formulate a plan, and the employer will say, oh no, nobody ever lifts more than 10 kilos, that's fine. And so maybe the information that's coming in from the employer might be a little bit different to what's happening in practice. So the OT is like, oh, well, they're fine because the employer has said they never lift more than 10 kilos
Yes.
anyway.
Yes.
So it's all going to be fine. So really then it's up to and it's hard because that's their livelihood, that's their job security. There's a lot of stress on them because they need their job, they want their job, and so they don't want to be rocking the boat, and they want to be contributing in the workplace, but then they're really running the risk of re-injuring themselves. So I always sort of try to encourage them to talk to their claims officer if the duties that the employer is asking them to do exceed what is agreed to in the return to work plan. And look, there's just often a reluctance of workers to call out their
Of
employer
course.
if they're not
But
doing the right thing.
sometimes it's been going on for years and years as well.
Oh, there's
Sometimes
a real
that
power
arrangement.
imbalance. Yeah.
Yeah. So I think the other thing that David's speaking to is that I'll get a physiotherapy to assess a patient. The patient can lift 20 kilos, so they can do a single repetition of, biceps lift of, I don't know, 10 or 15 kilos. So of course that means they're fully fit to do a full day of lifting 15 kilos
Yep.
1,000 times in one day. So that nuance that we want to try and get to, how do we incorporate that into our advice for WorkCover to say, sure, they can lift 15 kilos. It's not appropriate to make them lift it all day long.
When you're doing the medical capacity certificate, there's a whole bunch of restrictions, and you are able to write in there, one-off lifts only, no repetitive lifting, and you can put that in as a specific condition. And just to have a bit of a laugh, I had a Matagota trial earlier this year, and there was a lot of emphasis put on the OT report because the OT came out to his house and said, can you lift this bag of cement? And so there's all these photos in the report of my fellow lifting a bag of cement and doing these things. And the case put by the defense was, well, look, that he can do this. The OT has seen him do it. We've got photos of him lifting 20 kilos. And he was beautiful. This was put to him while he was on the stand. He said, never said I was weak. I just said I couldn't do things on a repetitive basis, and I couldn't do tasks where I looked up and I looked down. Never said I was weak. Never said I couldn't lift 20 kilos. And that just went such a long way in really showing that those functional assessments where, you do one task once really isn't reflective of what a day in the life of a builder actually looks like. So so yes.
Be careful.
That's
a word of caution.
There's a lot of difference between a one-off lift safely done, holding it close to chest, and then the actual realities of being on a work site where things aren't always performed as safely as they should be.
So I'm mindful of time, Beth. Do you have a punchline?
Oh, okay.
Yeah. Oh, we can. Don't hesitate. We can always do another one.
I'm up to slide 13 or 16, and I don't think there's. I think the couple of the last slides are a bit
brief.
Nothing. So so the test is, and I probably do want to highlight this.
I like this. So I've got a beautiful lady who lives on the tablelands, and she gets driving Miss Daisy, takes her all the way down to an appointment and all the way back again. But I've got a lady in Pomerol, and they say, no, we're not organising your flights. We're not paying or organising. You've got to pay for them up front and we'll reimburse you. Is that reasonable?
No, that's not reasonable.
Thank you.
WorkCover have, you get a bit, some mixed messages sometimes, depending on who you're talking to in WorkCover.
That's correct, Beth.
WorkCover will sometimes say things like, no, we don't fund that. You're applying for something. WorkCover doesn't fund that. We've got a policy. We've got an internal policy and we don't fund that. Push back on that.
Okay, you've never seen the policy?
Well, the policy is not legislation. That's an internal policy that they've drafted.
Okay.
The test that is applied is the rehabilitation reasonable and necessary? Not is the funding request meeting the WorkCover's internal policy of what they're going to fund. So be resistant if it's something that you think is necessary and it's reasonable and necessary, and WorkCover are saying, no, we've got a policy that says no. Bit of resistance on that. So there's all the things. They will fund your travel expenses for treatment. They will fund all your usual things. What they won't fund is unapproved providers. So you've got to, it's got to be an
massage therapist.
Yeah.
Chiropractors?
Yes. So if they're registered,
osteopath, yep.
Okay. Where they won't is because they might say, well, hang on, you're seeing a physiotherapist and now you want to see a chiropractor as well. And we think there's an overlap in the modalities there.
Wow. Really?
So you choose one or the other.
What about dietitians?
Yeah, they'll fund dietitians, yeah.
Oh my goodness. Okay. I've had that rejected.
Yeah, definitely. On the basis
that's fascinating.
That they have a policy that they don't fund it, or?
I'm not sure what the grounds were. I know, of course, once, I'm sure David's the same. Once you get rejected once, you think, oh, well, that's just the way the world is.
Again. Yeah.
I'll never ask again.
No,
okay.
Don't.
Dietitian.
Yeah, definitely.
Fantastic.
So they do work on an upfront approval process. So if you want a particular treatment, you need to ask them, they need to approve it, and then they fund it. So they get a bit antsy if you go and pay for treatment and then ask for reimbursement.
Oh, wow. Okay.
They're not huge fans of alternative and natural therapies.
No, I've noticed.
But if it's done by a registered practitioner under special circumstances, they will get on board. Where it's a bit exciting is that emerging treatments and services and things like that you can put forward, and like medicinal cannabis is sort of one of those areas
PRP
where
injections and
they really took issue with funding medicinal cannabis at the beginning, and again it was their policy and they don't, and certainly with the support of pain specialists and evidence that other pain treatments have been tried, tested, and not necessarily worked.
Working.
And then you can show that there's been a real journey before you've come to this point. Then it can very likely fall within what's reasonable and necessary for that particular patient. It's case by case, but certainly their internal policy to say we don't fund it just doesn't fly.
Right.
So,
excellent.
And sometimes we've got options to do applications and things like that if they reject funding. Did you want me to? I'll quickly speak to records, because I think doctors get really, really nervous when we request your records, and you think that we're trying to catch you out and we're trying to look for some kind of fault in the treatment. We're not doctors. We've got no idea whether there's fault in the treatment or not. Certainly not what we're looking for. When we're looking for it, we'll go to the date that they first attended on you, and we'll look at exactly what was written down about how they injured themselves. We want to make sure that's consistent with the incident report, what's recorded by the ambulance, what's recorded by the witnesses, what's recorded by all and sundry. So we want to make sure that there is that consistent reporting of how the injury happened and what the injuries are. We look at how the symptoms have progressed. We want to look, again, like I said, that consistency. We want to look at what's happened in the past. So we really are very, very keen. Like once they've been injured and they're having treatment, then it's, it's usually just the progression of that injury. Or if there's a fresh new injury that we need to know about that changes their ability to work or whatever, regardless of the accepted injury. So then we go back and look at their past symptoms, attendances, what are they complained of? What are the things that we need to be aware of? So if you've got, Peter and he's a bricklayer and he's 50 and he's sitting in your office going, oh, if I didn't hurt my back at work doing that, I was going to carry on being a bricklayer to 70.
Yes.
And that's what Peter's telling you. And then you look at his GP records or medical records, and Peter's been complaining about his chronic back pain for years, and he's been complaining about, that his shoulders are both stuffed and his knees are stuffed. And you're like, he's not going to be, there's just no way a court's going to accept that he was going to be a bricklayer. So it just helps us to really properly advise the person about the reality of whether or not, and then we can ask experts as well when we get our IMEs. Okay, this is their GP records. These are all the attendances for all these other things. Do you think they would have still been able to carry on in their chosen occupation until normal retirement age? So it's really helpful for us just to make sure, because that's one of the arguments that the insurers are certainly going to raise, that even if this injury didn't happen, there's no way they could have carried on working. So we need to know everything, the good, the bad, and the ugly. So we're having a look at all of that. So don't be concerned that we are like there's, and I used to actually write in my letters requesting records that the patient has no difficulty or no concerns about the care that's been provided by yourself. I just need your records. So just
that helps a lot.
Should I do that? I'll put that sentence back
because
in.
What the context is that we get APRA complaints, and the APRA complaint begins by stating that we have that they are concerned that we have caused a harm to patients, plural. Based on our action, right?
Yeah.
And so that is kind of their opening paragraph. And so offering some sort of element, we've asked APRA to offer us some reassurance when they write those letters to us, but they are concerned that they're not sort of getting our attention. So offering, so offering some sort of, this is not, like I'll open it up and sometimes there will be a request for records that is a little bit hard for me to understand. Thanks, David. You don't have to hang around. It's a little bit hard for me to interpret. Is this lawyer working with the patient? Is this lawyer working with the company that? So if offering us that,
including that,
it would be really terrific.
Yeah, because I think we just have a blanket letter that we sort of send out to all the treatment providers because we need all the records so we can properly brief our IME specialists. So I will certainly soften that so I don't cause any undue distress for you. Not a problem.
Less stress.
So definitely not trying to catch you out. There's nothing about it like that. The other thing is the records are the patients. So sometimes there's a misconception that the records are yours. The records are actually the patients, and the cost so the patients have an entitlement to those records. There's some very slim examples of when when you could withhold those records, particularly if it's likely to cause them harm. And that's more like if you were requesting psychiatrist records or something like that, where there may be something in there that could harm.
They've disclosed
the patient if they were to reread that. So, but really, by and large, you need to hand the records over, and the cost for providing those records needs to be an amount that reflects just the administrative cost and time to prepare those records and can't be in any way
onerous,
prohibitive of then the client, if the client can't afford to get those records, that it's preventing them. So the cost has to be a reasonable cost to of just an admin person pulling the records together and scanning them or sending them off. So there isn't a set scale for the cost of records. It's I guess depending on how many pages.
It'd be good to have a guideline.
And I think the WorkCover guideline, I think, is 25 cents. So I don't know when that was last updated.
Takes me a bit more than 25 cents to
I would have thought so.
To just but I mean, I try and value add by having a look and refreshing my memory. And is there something in there that was flagged that I really sort of wanted to communicate? That's what I'm looking for. But anyway.
Yeah,
Go
but
on.
that's probably, look, that brings me to my end and any questions.
So
And I think we've done questions along the way. So
we
if there
certainly
is
have. We
anything
tried very
else,
hard to interrupt you as much as possible.
you did well.
And the other things that when you come back and talk to us again, Beth, things like closing claims and
There's a whole,
imaging and
honestly, there's a whole another
permanent
hour
impairment
in this.
assessment. Yeah. Let's
Being
do
able
that.
to help your patients through that process and know what it all is, and be able to give them some kind of forewarning about what, because if I'm involved, I'll give them the warning, but I'm not involved
Yes.
in all the cases. So a lot of the time they are going into these IMEs, they have no idea what to expect. They,
But
it's
is that really
pretty
the
intimidating.
doctor's, sorry, just jumping in there, but is that really the doctor's job to actually gear them
Probably
up for
not,
these?
but if
No,
they
I
haven't,
don't think
if they
so.
haven't
we keep trying to
engaged
take it
a
on.
lawyer, then they
But
where
you
are
get
they
it
getting
wrong,
their
you take it on and you
information?
get it wrong is the problem.
I know.
And I
I know. And we
doesn't
feel
help.
obliged.
Yeah, I don't think, I mean, certainly you shouldn't be giving legal advice, but you can say, look,
I
you're
know.
going to see an IME. See, I've got a whole spiel. You're going to see a
That's
defendant
another
IME,
talk,
and
Beth.
Excellent.
but like just because they're sort of that whole trauma-informed practice, these are clients who've had their whole world ripped out from under them. They've had this accident, they can't work, their relationships are suffering, they're in a very depressive state. And then we're putting all this pressure and we're re-traumatizing,
Yes.
and we have to be really mindful of like doing the least harm. Isn't that your motto?
Absolutely.
And so
Hippocratic oath.
seriously, just giving them some information and go, this is what to expect. The defendant doctor may not be the most warm and fuzzy doctor, and they're not going to necessarily, make you feel at ease. That's not their role. Their role is to assess you. They're not there for treatment. They're going to ask you these sorts of questions, and just to forewarn them so they're not completely caught off guard and then having a complete breakdown after the assessment because they didn't know what was going to happen.
So distressing sometimes.
What about a handout? That would probably be better, because then you're not going to change it each time. You could actually say, look, if you're doing an IME, we have a handout for you.
Yeah, look, I do. Yeah, and I do. Yeah, we do offer them information, but once again, as Beth says, you're stepping into that legal territory, and my preference now is to just say, you need this. This is complicated. I do not have this skill set.
Yeah,
you need to talk to your lawyer.
I mean, it would be as ridiculous as me
yourself.
telling them what surgery they need. Like I just wouldn't even.
Yeah, but
I don't know.
It's hard to get them across to feel confident enough to ask for help in that regard. To ask for help, for legal help. So. Thank you, Beth. I cannot say how grateful I am that you've taken the time tonight, and I'm sorry that we've run over.
Helpful. No, I had no idea how long it'd go for, so that's really good. Thank you.
That's what I want. I just want that sort of opportunity to just chat, and I hope that we'll edit it out and try and get some little snippets out of that to sort of share with the GPs on our network. So save you doing so many talks. Great.
Thank you, Sarah. I appreciate it.
Thank you, Beth.
You have a good night.